Okay, welcome back. We're in Module 2, looking at the evidence. This is Liz Carlson,
And Beth Staffolino.
and we look forward to going through this module with you.
So let's start out by considering what is evidence. Now you have a core and it's valid in current research, but not all evidence has a research base. While it is the preferred and ideal evidence, that's not always practical. So you may need to search for additional evidence to support your core. For example, there may be case studies that you may include. Certainly, as we mentioned before in the previous module, you have to consider patient preferences and clinical expertise. So the more sources that you can add to your core, the stronger it becomes. So think back to the previous module and the discussions we had about formulating a clinical question. And, we talked about the PICO format. So one of the first key steps towards formulating your question is also taking into account what evidence is available. So how do you search for evidence? And you go into the literature and look for current and relevant articles and other resources. And there are many databases that are available. For example, CINAHL and Medline. There are other databases that are free to the public, such as PubMed. Some of these databases do require a subscription. A password may be needed. Oftentimes you can access these databases through a hospital or academic health science library. But we've listed on this slide CINAHL and Medline, which are two common databases. The CINAHL is the Cumulative Index of Nursing and Allied Health Literature. It contains a lot of the nursing and allied health resources and articles, as the name suggests. Medline is a government database that is a little more widespread in the fact that it contains medical, nursing, dentistry, psychiatry, and even veterinary and allied health resources. There are a couple other databases worth mentioning. Embase contains a lot of biomedical and pharmaceutical studies. If your need is more psych or psychology related, you might want to look into PsycInfo. The Cochrane database of systematic reviews, and we're going to be talking about systematic reviews soon, but this is a nice database that really provides a wealth of information in one systematic review. And then the Jonah Briggs Institute Library is just a repository of nursing and health professional related evidence-based practice studies. There are also, depending upon your question that you're searching, there are databases that provide guidelines and systematically develop statements of care. For example, the National Guideline Clearinghouse is one that is supported through the Agency of Healthcare Research and Quality.
So what are the key things, the key steps, essential steps for starting a search? Well, back to that we talked about earlier, you need to formulate your question. You need to be very clear as to what you're asking, because otherwise what you're going to be searching for will include soup to nuts. So it's important to spend time on formulating and honing your question. Secondly, you determine the type of database that would be appropriate for your given question. Obviously, if you're looking for, as Beth mentioned, psych or psychology related information, you'd go to the PsycInfo versus the one for veterinary medicine. Third, you determine the type of study design that would best answer your question, and we're going to talk about study design shortly. Then you enter the subject heading, and this gives you the first go through for your search. You may need, I'm sure you will need, to combine searches based on various headings, subject headings, to find the relevant evidence.
I just want to add one thing. In relation to this, we've talked in the previous model about these projects, whether it's evidence-based practice, research, or a quality improvement initiative, really are done as a team. So especially if you're doing this for the first time, you might want to consult with a medical librarian or someone else who is familiar with these processes of literature searching. You might seek out your head nurse, a clinical nurse specialist, or some other advanced practice nurse that may be familiar with searching. So what is considered evidence, and how do we rate it? As we've said all along, the goal of evidence-based practice is really to use the highest quality of knowledge when we are providing care. And there's a number of models available to guide the process for rating evidence, because we want to look at the stronger evidence to use for our patient care decisions. Evidence can range from rigorous to weakest, and levels are assigned based on the rate of the strength of evidence. Lastly, you also want to consider the quality, quantity, and consistency of the body of evidence. So, as I mentioned, there's a number of taxonomies to rate varying levels or the strength of evidence. This table is pretty standard in terms of the leveling. So a level 1, as you can see, is considered the strongest evidence, and we're talking about meta-analyses or systematic reviews, or many controlled studies or clinical trials that are combined together. Level 2 would be considered something related to an individual experimental study that contains randomization. And as this goes down, you can see that the weakest level of evidence are opinion statements, or an expert committee putting something, opinions together. So they're not that, if you think about that in comparison to a systematic review that has multiple clinical trials looking at evidence as compared to an opinion statement. This is just this pyramid presents that table that we just showed you in a different fashion, but it's showing that the systematic reviews at the top of the pyramid are the strongest, but there's probably fewer of those in comparison to editorials or opinion statements. And again, you can see that the randomized controlled trials are the next strongest, followed by cohort studies, case controls, and just case reports.
And I would add here that if in the course of your searching you run across a systematic review that is related to what you're doing, make sure you retain that reference, because much of the work of gathering the strongest studies together and evaluating them has already been accomplished. And this serves as an excellent resource for you, if for nothing else, than to give you additional references in which you might be interested.
So also consider looking at quality, quantity, and consistency. So quality, you want to look at relevant studies for a given topic, where quality is really looking at the design of the study. Was it a randomized trial compared to a case control? You want to look at the quality of the design, and we're going to be getting into design issues shortly. But is the design one that is strong, or does it contain a lot of confounding variables that may make you question the strength of the findings? The quantity is, what is the treatment effect, what is the outcome, and also the quantity in terms of, have other studies supported this finding, or is it just one study and many others that are differ? And then consistency takes a look at the extent of similar findings reported from work using either similar designs and populations, or different studies and populations. Also, when you're considering evaluating clinical guidelines, because we use those in our practice too, you want to look at information that is current and reliable. And the U.S. Preventive Services Task Force have grades that they have recommended based on the strength of evidence. So this taxonomy just looks at, for example, a grade A is something that as a clinician you would be able to recommend and provide to patients with strong support from evidence, in comparison to a grade D that you probably wouldn't want to routinely recommend unless there was no other choice. I mean, you have to look at weighing harms and benefits. And a grade I just means that there is insufficient evidence to make any kind of a recommendation.
So we're now going to move into looking at research designs. The question related to the research design is, first off, what is your question? Before you decide what research design to use, it is important to, again, say, what is my question? What is the problem? How do I have a focused problem? Then you look at, what have you found in the literature? What does the literature say about your question? You decide whether there's a theoretical framework within which you're going to frame your study or your work. You may or may not. What is the study purpose? These four aspects will influence the selection of a study design. So there are three ways that you'll see study designs referred to, or there's three ways of categorizing them. They can be categorized by design, experimental, quasi, non-experimental, by time, or by type of research. So first we're going to look at by design, which is experimental, quasi-experimental, or non-experimental.
Okay, experimental designs really have 5 key features that you should keep in mind. One is adequate sample size. Oftentimes, and this is where you may work with your team, especially a statistician, because a power analysis may need to be calculated, because you want to make sure that you have a sufficient sample size that will help you in looking at the outcome. Also, in experimental design, you have randomization. So this involves having subjects or participants assigned to either experimental or comparison group. And this is often done based on a chance determination. There are electronic programs that provide computer generated randomization tables. Again, this is something that a statistician can help guide you with. But the key thing is to remember that experimental designs involve some kind of randomization and manipulation of a treatment. Oftentimes, the larger the sample, the greater the chance of your groups being very similar, which is what you want at the outset. Experimental designs often include very specific inclusion and exclusion criteria, and this may impact your ability to make grand generalizations. And we'll talk about that a little bit later as well. Again, the notion of the intervention, you can have a comparison intervention, or you can have standard of care compared to an intervention, a placebo intervention. Again, there has to be some kind of manipulation, but both groups have to have a consistent delivery of procedures. Also, with experimental designs, you need to be able to consider controlling extraneous influences or biases. Sources that may interfere with the intervention or may confound variables. Again, this goes back to when you're designing this type of a study and having very precise and specific procedures to follow, protocols. Lastly, you want to take steps to ensure that your participants stay in the study. You want to avoid having missing data, because at the end of the day, how are you going to explain your findings, your outcomes, if you have a large amount of data that's missing, that hasn't been collected? So let's give you a little example of what this looks like. And this schematic shows what a pre-test, post-test experimental design may look like. So you have randomization of two groups. The R is for randomization. O1 is your pre-test. Your X is some kind of manipulation or intervention, and then you follow it up with a post-test.
And as you can see here, everything across the board, across this schematic, is the same except the X. One group received the treatment and another group did not, or one group received the intervention and another did not. That's what forms the underlying basis of this experimental design.
Okay, although experimental designs are strong and considered, especially randomized controlled trials are considered the gold standard, there are some limitations. Because of that very strict inclusion and exclusion criteria, you may not be able to generalize to the general public. So findings are reported as average outcomes of the two treatment groups, but what if your particular patient population is not part of that average? Again, there may be a weak external validity due to that specific inclusion and exclusion criteria. And experimental designs, the interventions are delivered in a very precise and controlled environment where we have strict protocols. So again, how does that relate to the general public?
And I would add also, not only to the, how does it relate to the general public, but how does it relate to the situations within which you would be delivering the care? There might be an excellent experimental study that gives you that you think this would be great. This is really what we need for to make these changes we need within our population. But you have to look closely. Is it the same population, and are the conditions the same?
So let's give you an example to hopefully put this all into context. So an example of an experimental design would be something like this, that the purpose of a study is to compare the effectiveness of the inhalation of isopropyl alcohol from a 70% PrEP pad to the drug promethazine in a treatment of post-operative nausea and vomiting in patients who are at risk for post-op anesthesia, nausea, and vomiting. So the design has two groups, and patients are randomized to one of these two groups. So you have the elements of an experimental design.
The other thing that you have here is that as I understand from the world of CRNAs and post-anesthesia people, which I am not, but as I understand, a common standard treatment or way to help patients reduce nausea is to let them inhale this PrEP pad, this alcohol-based PrEP pad. So that would be, or could be considered, the usual care, versus giving this medication, promethazine, could be considered the different experiment. So that would be the X in the picture before would be the drug promethazine. So that is another way for you to visualize this.
Okay, another type of design is the quasi-experimental. These are not quite as powerful as the previous experimental designs that we just talked about, but because it's lacking the one important feature and can lead to uncontrolled extraneous variables. Let me give you an example. There may be non-equivalent control groups, a pre-test, post-test design, a time series design, and a pre-experimental design. So here is a schematic, and as you can see from the outset, we're missing that key feature of randomization. So you can have your pre-test with providing X, that intervention, followed up by a post-test, but you don't know from the outset if these two groups are similar because you're missing that piece of randomization. So let me just give you a quick example. Let's say you want to study the effect of introducing a new hospital-wide model of care, with the main outcome being patient satisfaction. So that this model of care is being implemented throughout the hospital, so therefore randomization is really not possible. So you decide to collect data in a hospital that you think is similar, but that hospital is not implementing that same model of care. So patient satisfaction is collected at both hospitals, but you can't say for certain that the two groups or the two hospitals are equivalent at the outset. Non-experimental designs can be descriptive in nature, correlational, or looking at model testing. So descriptive would be when you want to do exploratory or comparative surveys, where you might want to describe a certain phenomena or a certain population. For example, you want to a descriptive survey, a descriptive design, just describing just describing palliative care patients who receive consultation on hospice care. You want to be able to describe that particular patient population. A correlational design is interested in looking at relationships between two or more variables. And model testing is, you might be testing theoretical models.
And I would say, Beth, that probably people listening to this module are not going to be moving into model testing as one of the first things that they do. But it is another non-experimental design. So the second way that designs are categorized are time-based, retrospective or looking backwards, cross-sectional, or longitudinal or perspective, which is looking forward. So in relation to a retrospective study, it can be called ex post facto. And this, within nursing, we do see retrospective design used regularly, because what we do is we look at what the dependent variable is. So we look at what has happened now. What do we have now? And then we look back in time to determine if there's any possible causative factors. So because the dependent variable has already occurred, the independent variable cannot be manipulated, which is why it's not as strong of a design as an experimental design would be. Subjects cannot be randomly assigned. The subjects that are in the study are the subjects that have this dependent variable. So you're not putting subjects into two different groups. This is the group you have, and you're looking back at what possible things may have caused the variable that you're looking at this moment.
Yeah, I mean, I would say that this is a common thing in nursing research, is doing chart reviews.
Right.
So that's what this retrospective design is. It's just, going back in time and looking through charts or EPIC or whatever.
And an example that we can give you of that is comparing patients, infants with sudden death, who died from sudden death syndrome, with patients who did not die from sudden death syndrome. And what differences do you see between those two groups? So the dependent variable in this case would be whether they were alive or not, whether they died of sudden death syndrome or did not. And you would look back to see what might have resulted in one group dying from this syndrome and another group not dying from this syndrome. What might be causative factors?
Another type of design is the cross-sectional. This is, again, a non-experimental design used to gather data from groups of subjects at one time point. So, for example, let's say you wanted to look at blood pressure at just one period of time in a cohort of high-risk individuals. So this is not, I mean, it's just a snapshot. It's like taking a picture on one particular time point. The issue with cross-sectional designs is that they can be hard to establish cause and effect relation or cause and effect associations since it is just a one-time data point. And often these types of designs need some kind of a theoretical framework that is strong enough that will help the researcher be able to draw some conclusions.
Another form of this cross-sectional is the cohort comparison studies. So for example, an example of a cross-sectional design is adolescent self-efficacy and condom use. One-time snapshot, what are the dependent and independent variables on that? It also might be looked at from a cohort comparison studies where you would look at adolescent self-efficacy, condom use, in relation to what year in college are they, or what year in high school are they, freshman, sophomore, junior, senior, and see if you see any relationships or any possible things that you could draw some inference from.
Okay, another design by time, so to speak, are the longitudinal or prospective designs. And these type of designs gather information about subjects or participants at more than one time point. So that differs from what we just said about the cross-sectional design. These designs can be experimental or non-experimental. You see these done with those large epidemiological studies, the women's health study, the nurses' health study. These large prospective studies, while they provide a wealth of information, can be costly, and they often require large sample sizes. But these studies are stronger in comparison to retrospective chart reviews. So some of the examples of different types of longitudinal designs are panel designs, where subjects can be used to provide data at multiple points in time. Or you can have a trend design, which may be non-experimental design, to gather data about variables of interest from different samples from the general population, but across time. And then you can have follow-up studies, follow-up designs. One example would be the Framingham heart study that started 30 plus years ago out in Framingham. That really was one of the first longitudinal studies that identified many of the cardiovascular risk factors that we now know about today. But they followed the original Framingham cohort and now are doing offspring of that cohort. So that has been a longitudinal design for many, many years that is still ongoing.
So the last categorization is qualitative versus quantitative research. Qualitative research is an approach for generalizing knowledge using methods of inquiry that emphasize subjectivity in the meaning of an experience for the individual. The key words here are subjectivity and meaning of the experience. So these are the types of approaches used for this are phenomenological research that looks into insight into the human experience, grounded theory, and this is used to produce a theory or to understand some social processes, such as family decision making, to have an organ transplant for one of their family members, or ethnographic studies, and that looks at healthcare subpopulations and describes them within those subpopulations. The, the thing with qualitative uh, research is that it generally looks at things that are not countable. You might be able to count that X number of people said this, but you can't very well count the process of the decision process that goes into having an organ transplant. There isn't a 1, 2, 3 level of decision making on that. You can't count it. And quantitative is the approach for generating knowledge that looks at how much of a given behavior, characteristic, or phenomenon is present. So quantitative is, in my mind, I always think of that in relation to counting. How many of this, what is the blood pressure? How many millimeters of mercury within the blood pressure is the difference between the groups? How many men are in this? How many women are in this? Those kinds of counting situations.
Lastly, we just want to mention about the randomized clinical trials. We've said that we've alluded to them numerous times throughout this module, but these really are the gold standard. And it's not a type of design that you would probably do for your first venture in research or putting together your first study. But this is, we want to mention this because this is the gold standard. But as you're evaluating your evidence, this is really something to strive for and to think about when you're evaluating the literature. But they often use larger, diverse samples in a variety of settings. And the thing with these trials, you do have to strictly adhere to experimental design principles, those 5 things that we talked about earlier, and sticking to the protocol. So they can be costly, they're labor intensive, but you also need to make sure, or the goal is to maintain participant adherence in these trials. When you think about some of the drug trials that are done, or device trials, you really want to avoid the missing or dropouts of your participants.
The other part of randomized clinical trial that you may read about, that you may have heard about, is in relation to blinding of patients and healthcare providers. And really what that means is that the intervention, and it's usually a drug study, the type of drug that is given, whether the person is in the randomized group that's receiving the placebo versus receiving the experimental medication, or however the designs are set up. But the medications then, as an example of blinding, they're made to look exactly the same so that the patients don't see a difference. The healthcare providers don't know they're giving a different medication, but they give the medication based on the patient's name, and all that blinding is done behind the scenes. So when you hear about a study that was blinded, that's what they mean. They just want to make sure that it is as fairly objective as possible.
And that's just to decrease any bias, right, whether it's on the participant or the healthcare provider side. So I think this wraps up The second module, we've covered a lot of information where we really looked at how to search for the evidence, how to evaluate the evidence, and then we just began looking at different designs of research studies.
So this is the end. We'll see you at module number 3. Thanks again. Bye.